morning, everyone. My name is Henry Stevenson Perez. My nickname is Steve, and I've been practicing cancer medicine since 1970, and most of that time I've been a part of a research team that's been trying to find a immunotherapy for cancer, and specifically today we're going to talk about melanoma. I'm really grateful to be part of this historic conference on skills building in cancer immunotherapy, specifically for melanoma. I'm joined by 3 other people in this room. I'll briefly introduce them and let them talk to you a little bit. One of them is Ananya Malcha. Ananya Malcha is a cancer researcher from Catholic University who spends a great deal of time with our melanoma immunotherapy team and our patients. She has a wide variety of remarkable skills, which she's going to be demonstrating to you shortly. And to my left to my far left is one of our patients who has graciously and generously, courageously volunteered to go on the national stage, Mr. Richard Banks. Can you wave your hand, Mr. Banks? Great. And he's, we've known each other for a really long time. He has a remarkable story, as you'll see, and we've been through a lot together. And he's joined by his primary caregiver. He's got a lot, but one of them is his wife, Harriet Banks. Can you wave your hand, Mrs. Banks? Great. And so what I'd like to do now is just briefly allow the 3 of you just to say a few words to the audience.
Hi, everyone. Good morning. Thank you so much for attending this conversation. Like Steve just said, my name is Ananya Malcha, and I feel really, really honored to be here. It's a great privilege to be invited to be a part of this conversation, and hopefully you're going to enjoy it as much as I do. One housekeeping item that I have is that we have got 60 slides here to present, and I apologize for that. At the same time, if you don't have the slides with you, then please feel free to email Sang Kim. He is in this meeting right now, and he'll be happy to send you the slides personally. Or you can also wait until the presentation's over, and you can email me directly after. And my email address is malcha, MALCHA, @cua.edu. So feel free to email me afterwards, and I can send you the slides too. The big point that I want to make here is that we want everybody to be super relaxed and super comfortable. Don't worry that you don't have the slides. We want to make this as easy breezy as possible. So just email Sang Kim or email myself. Email me after the presentation's over.
Yes.
Mr. Banks, would you like to say a couple words to the audience?
My name is Richard Banks, and I'm here to talk about my experiences that I've been through and the strengths that I've been having to take me through this, and my hope where I never given up on this disease, and my prayer and with the doctors who have gave me so much inspiration and going through this experience of having such a disease that I've been going through over 20 years now.
Yes, I'm Harriet Banks. Richard and I have been married for 49 years, and this has been quite an experience for us, but through our love of Christ and through his love for us, we've been able to get through it. It's been challenging, and but we've gotten through it, and he's been here for a while, and I'm so glad, and I hope he'll be here a little while longer.
I think the lead-off slide really tells the story of what we're here to talk about today. It turns out that there's 2 dramatically competing scientific models about what melanoma could be. And these, in turn, shape 4 very different approaches for treating the same disease. And we're here to share with you what these, it's very complicated, and we're here to make that complication easy. But it takes a little practice. This picture, I think, gets a sense of it. I don't know how many of you can see 4 figures in this picture, but if you focus on the lady, the girl with blonde hair looking at a book at the front, and the man with the cape behind her, and then you'll see an arch that they're under. But then look behind her hair, and you'll see a woman moving towards a building in the background. And then, of course, there's this overarching figure, which is this kind of like Darwin kind of character that's framed by all of them. What you'll notice when you play with an image like this is that it's almost impossible to see all 4 at the same time. You just kind of have to walk through one and try it. So that's a metaphor for what we'll be doing next. Who's changing the slides? Could we go to the next slide, please? So this is the nuts and bolts of why this is possible. Obviously, we're in a very, very rough time for the world, and certainly for medicine. It's extremely stressful, and we've had to make extraordinary accommodations. And I want to thank everyone that's at the leadership, and I specifically want to thank the young leaders in the dermatology residency program, Sang Kim, Michelle Bongiorno, Alexandra Rosenberg, just not letting anything be an excuse to move forward. Let's move forward. So the first goal of this workshop, this privileged time together, is to strengthen the scientific platform for exchanging information about cancer immunotherapy diagnoses and the resources that are available. It's not just between the derm staff and their oncology colleagues, but in our institution we have 8 different disciplines that have to work well. Dermatology, obviously, surgery of many types, not just cancer surgery, but plastics, ENT, etc. Chemotherapy, immunotherapy, radiation therapy, radiology, interventional radiology, and of course many different kinds of pathology, of which the most important is dermatopathology. These are very exciting fields because each one of them is doing a lot of stuff. How can they all come together to help each specific patient? At our institution, the strategic plan was just always to focus the leadership on the youngest among us. So at our institution, the Cutaneous Oncology Tumor Board is run by the young residents. And they have to have the big picture, they have to coordinate the conversations, and they have to put the action plan together. It's amazing that it has worked so well, but it does. And we're here to strengthen that conversation. We also want to make it easier for all of us through the voice of Mr. and Mrs. Banks to really want to be able to see this whole problem through the eyes of patients, and what tools can we share to allow them to collaborate with us. Sorry for the first bullet. The second bullet is the quick one. Everything that we're presenting is just personal views of presenters, has nothing to do with the position of any federal agency or academic institution. The bullet number 3, we've done everything possible to keep everybody safe from COVID for this presentation. There's only 5 individuals in this rather large room. There's the 4 of us, and we have a cameraman who's recording this for a YouTube posting. And we've created, you may not be able to see it, but there's a plastic barrier between us to protect Mr. and Mrs. Banks. We're in and out of different kinds of masks all the time, and gloves, and everything's been sanitized, and we're just doing the best we can to keep everyone safe. Nanya and I work very closely together with patients, so I think we understand how to keep ourselves safe. We have no conflicts of interest to report. I want to talk about the special protections for Mr. Banks and Mrs. Banks with regard to patient privacy. They have reviewed all of the slides that you'll be seeing. We have printouts of them, etc. And they have approved the content. And in addition, we'll be posting a YouTube video, which is the next bullet here, and they will be looking at the YouTube video as well before it gets posted anywhere. So they're entirely in charge of the content. At the same time, the clear understanding is at the end of this workshop, that's the end of that. They go right back to being just fully protected by HIPAA privacy, just like anyone else. And the last idea here is that we will be broadcasting this on a YouTube posting later on. Well, it's being broadcast now, so just normal caution. Don't do anything or put anything on the digital monitors that you don't want the rest of the world to see. I think we're ready for the next slide. So quickly, we do have 51 or 61 slides?
60 slides.
60 slides. And our goal is to get through as much of it as we can. We have some board review questions. We've got a review of the cancer immunotherapy revolution in general. We have a case presentation, specifically Mr. Banks, and it's in the COTB format, the Cutaneous Oncology Tumor Board format. Ananya Malcha is going to help us to kind of understand how we got to this conversation today to help us to get where we need to go, which is item number 5, the cell survival basics that are governing all immunotherapy decisions. Number 6, we'll be talking about why disease models matter with regard to melanoma treatment. And the 4 big ones, of course, are surgery, chemo, radiation, and immunotherapy. We'll then be talking about the patient the patient dimension of this melanoma puzzle that we're trying to solve. And separately, and we'll ask Mr. Banks to talk for around 10 minutes. And separately, we'll talk about the caregiver dimension, and we'll ask Mrs. Banks to talk. We hope we have time to go back to the case study about some of the key items that we want to know more about in this particular case, and also to answer some of the board review questions before we get to conclusion. That being said, the strong belief that I've learned from this process is that every step we take going forward here is moving your skill set forward and certainly helping us collectively to gain language for making sense of the melanoma puzzle. And while we really want to get through all the slides, and by the way, we also have a journal review article on it that just came out in 2020 in the dermatology literature that Sang Kim has for you as well if you don't have it. Or Ananya can send it to you at the end. We would love to get into that today if we can. But if we can't, the only thing for sure that we're going to end on is to make sure that you hear the testimony of Mr. Banks and his wife in their own words and make this as interactive as possible. And finally then, in that spirit, we do want to make this as interactive as possible. Saying, I'm not sure the best way to get everybody involved, but we definitely want them to feel free to unmute or to chat or however we can get your questions. We'll just stop wherever we are and start to be where you want us to be. So briefly, we're in something called the Cancer Immunotherapy Revolution. You don't need to take my word for it. Go to the March 23rd, 2018 edition of Science, and you'll see why this is so completely different than anything we did in the 20th century. And our goal, again, today is to empower everyone who's listening to ensure that there's maximum participation of all the different disciplines. Remember, each one of them is experiencing an explosion of new research in their own regard. How do they bring this in a seamless, coordinated fashion together for the benefit of the patient? One last thing, we have a new window of research opportunity now, the moonshot. The real moonshot is a cancer immunoprevention vaccine. That's a realistic possibility for Americans today, and we definitely want to keep directing that. As Nanya and others will emphasize, we don't really know where that's going to come from, and I surely wouldn't assume it's going to come from any of the established institutions. It could very easily be an idea that comes to your mind right now. That's how it's kind of been so far. Next slide, please. Here's our lead-off dermatology board review question. What's going on with this patient? What would you do? Is she a 70-year-old woman, metastatic melanoma, treated with an anti-PD-1 therapy? After 6 weeks, she develops tender erythema with blisters. It starts in her hands, but starts to spread rapidly. What do you do when this patient shows up in clinic? Next slide. So let me briefly now jump into the patient treatment summary. This is condensed from the way this case would be presented in COTB, but this is the basics of it. So you're looking, we have the privilege to review a 20-year-old battle, 2 decades of battle with melanoma, starting in 2001, when the patient, who, as you clearly can see, is African American, develops a T1A left foot plantar lesion. It was resected at our institution with a wide local excision. He's had amazing surgery all here, and it's been heroic, and what you're going to see in a second, because all he had to do was worry about it for a long time, and then suddenly in 2013, it comes back on the left lower leg skin. The sentinel lymph node was positive. He had a left below the knee amputation and an inguinal lymph node dissection. As you all probably know, those have consequences, side effects that have lingered, and he can perhaps talk about that. 2014, he develops new left popliteal lymph nodes and has a resection of those, and then receives a 30 gray of adjuvant radiation therapy. Unfortunately, the tumor was BRAF negative. We'll describe those implications in a second. By November 2014, he has new disease in the left groin, and our melanoma tumor board, or cutaneous oncology tumor board, recommended surgery to render the patient NED, and he was treated with 4 cycles of adjuvant ipilimumab. In May of 2015, the therapy was completed, and he remained NED for 2 years. But then in June of 2017, he developed local metastatic disease in the left thigh and began immunotherapy. But then in September of 2017, developed metastatic lesions in the abdomen. They were symptomatic. It was a big mess. And we switched to Pembro and low-dose IPI to try to switch it up. And we'll be talking about what we mean by switching it up when we're trying to communicate with the immune system of a patient. In March of 2018, a new melanoma nodule in the left thigh was excised, returned to NED status, and we elected to keep him on Pembro. In March of 2019, his PET scan was negative. In June, he had another local recurrence and the left stump of this year. It was confirmed to be a melanoma, and we elected, because of his great progress, to keep him on Pembro, which he's on today. In fact, he and I will be seeing each other in clinic tomorrow to get, gosh, it's been, what number, Mr. Banks, of how many Pembros have you received?
Well, every 3 weeks for the last, 2 years?
Yeah, so it's like 60 or so? Yeah. It's a huge number. Okay, so Sang, would you like to present the path?
Yes, sir, thank you. So here we see a large mid-dermal-based nodular proliferation comprised of atypical and mitotically active cells that are largely arranged in sheets, but also interspersed haphazardly into nests and cords. Scattered limbs are noted, intermixed between the atypical cells. These cells stain strongly and diffusely positively with SOX10.
Well, let me just do a little bit of bragging before I do anything, and that is, number one, to thank Sang for his review. He's, again, one of these very young dermatologists that's sort of taken ownership of the whole huge field of melanoma. Again, the type of person who grows very quickly into this field and has helped us at a national level to sort of coordinate our thinking patient by patient by patient. And that's the goal, to help every one of the participants to be able to master the same material and the same process the same way. It's a shame that we don't get to talk to Grant Bonavia today. He is just on the other end. He's extremely senior. And for any of you who have access to him and have questions, I don't know of anyone who's studied the imaging of melanoma more than him, and particularly with regard to immunotherapy. Please keep him on your short list of people to contact with questions. So let me just briefly start the imaging. There's the PET scan of January 2013, which shows this melanoma recurrence after the original diagnosis so many years before. And you can see the left foot MRI, which shows a T2 enhancing mass on the left plantar foot. Next slide, please. The popliteal fossa PET scan on March of 2014 shows a nodal recurrence, and as you can see, he's already had the left below the knee amputation. In addition, we see on November of 2014 the left external iliac nodal spread of disease. Next slide, please. In March of 2020, there's a left posterior thigh subcutaneous reoccurrence, which had to be excised. And you can see the thigh MRI of that same area. This was successfully excised. And here's September. If we go to the last slide of the next slide, in September of 2020, he has no evidence of metastatic disease. And that brings us up pretty much to today. So with that, if we could have the next slide, please. I'd like to turn this over to Ananya Malcha to help frame kind of how we got to here and where we could go from here.
So I'd like to start at the top right-hand side corner where it says ICI Immunotherapy. ICI stands for Immune Checkpoint Inhibitors, and we've been with this type of treatment since 2010, and that's where the big deal today in melanoma is. In addition to that, I'd also like to make a huge point for this slide specifically, that cancer medicine is just a conversation. Cancer medicine has always been a conversation, and it has its highs and it has had its lows, just like any other conversation. And I'm hoping that everybody in the audience today will consider where this November 5th conversation can go. For example, Steve, later in this presentation, will be talking about the importance of ultimately developing a cancer immunoprevention vaccine, and this conversation could easily be seen as a stepping stone for that. So I'm hoping that you'll have an open mind during the next 1.5 hours or so. So now we're going all the way to the left-hand side of this slide and going to 1846. We're first going to cover the black lines on this on the timeline. The first one in 1846 is the discovery of anesthesia, and that led to the first cancer surgery, and that was when the cancer surgery theory was developed. In 1831, we have a surgeon named Cooley, and he figures out a way to do cancer surgery and then actually leave microorganisms on the surgical wound to be able to do a final cleanup. And believe it or not, we're doing a lot of that today as well. We're just a lot more refined in our thinking, but the basic idea is kind of the same. In 1903, we get our radiation therapy series, still a big deal today, by Grubb and his team. And I'm just going to jump over the red line there and move to 1941. This is when we figured out how to use hormonal manipulation to treat breast cancer and prostate cancer. And we still do that today. In 1942, that was when the standard chemotherapy model of cancer medicine was developed at Yale. And the big idea there was to give as much chemotherapy to the patient as possible that they can tolerate. And then jumping over to 1983 to adoptive immunotherapy. There's many different types of adoptive immunotherapy, as Steve will be talking about later in the presentation. But the two big ones in 1983 were TIL, which stands for tumor infiltrating lymphocytes, and AKM, which stands for activated killer monocytes. And then in 1985 was the discovery of monoclonal antibodies. There was a Nobel Prize won for that. And then in 2001, we moved on to TKI, which is another type of chemotherapy, very, very close to that. And Steve will also be discussing the details of that later. And that gets us to immune checkpoint inhibitors to present day. As I was saying before, cancer medicine, just a conversation, has had its lows like every other conversation, and that's what these red lines that you see here show. So from 1700 to until about 1910, we actually thought that cancer was a communicable disease. And that obviously is wrong, but it took us 200 years to shed that idea. In 1980 was the development of something called the Goldie-Coleman hypothesis. And it basically says that the maximum tolerated dose of chemotherapy is the best dose that you can give to a patient to be able to help them. So the idea is to give as much chemotherapy as possible and to then in 1990 try to do a bone marrow transplantation to actually rescue the patient from the chemotherapy that you have given to them. So hopefully this slide is helpful to you in understanding how the cancer medicine conversation has evolved. And just a fun fact that I found out like a couple days ago that I thought would be fun to share with you guys is that the Society for Dermatopathology, what you guys specifically are interested in, that was only developed in 1963. It's very, very recent, and the field itself is recent too, but it's surprising how much we've learned. Could I please get the next slide? Thank you. So now we're moving specifically to be able to understand melanoma as an exercise in cell survival and how it specifically is related to cancer immunotherapy. But to be able to do that, we must start from the beginning. And when scientists talk about what it means to start from the beginning, we literally mean the beginning. So hopefully you guys in the audience are able to recognize this figure in the background. It's an image of our very early universe, just 300,000 years after the Big Bang. And it shows, the picture shows that our universe is not homogeneous. Specifically, it shows two different types of spots. The first one is these red and blue spots that actually show the forces of meaning. This is things coming together in support of higher levels of complexity and sustainability. The opposite of the forces of meaning are shown here in dark blue, in kind of the middle of the image. And the forces of entropy are opposite of meaning, and they show things moving farther and farther away from each other to maximum states of randomness and lowest states of energy. And these two forces, the forces of entropy and the forces of meaning, have been around since the very beginning of the Big Bang, starting about 14 billion years ago. So moving on to box B on the top right corner, now we're fast forwarding from the Big Bang to 14 billion years ago to about 4 billion years ago, which is the beginning of first life. This is the beginning of successful single-cell organisms, and none of them actually have any nervous systems. And there are specific functions that these single-cell organisms must be able to do in order to actually successfully survive. The first one is they must be able to identify and combat the external forces of entropy. Basically, staying away from toxins, doing toxin avoidance, and avoid being lunch of other organisms. They also must be able to successfully export the internal forces of meaning that are inside them. And it's very, very complicated the way they do that, the way bacteria, for example, do that. And just one of the ways that they do it is something called CRISPR. CRISPR is a very, very complex system, and I'm not claiming to fully understand it, and it's really a topic for another conversation. The second thing that these successful single-cell organisms must be able to do is continuously identify and embrace the forces of meaning in their external environment, such as food energy, which is basically finding free energy, and be able to embrace the forces of meaning that are inside of them, basically reproduction and maintaining homeostasis. It's obvious, but it's really important to state that single-cell organisms, such as bacteria, do not undergo malignant transformation. They don't get cancer. Moving on to box C on the bottom left-hand corner. Now we're going to successful pre-vertebrate multicellular organisms, either with or without a nervous system. These are organisms that make up about 95% of the entire animal biomass on the planet. These organisms must still be able to do the same functions as the single-cell organisms that I just described. Be able to continuously identify the forces of entropy in their external environment and stay away from that. Do toxin and threat avoidance. They also must be able to avoid being eaten from other organisms. And they also must be able to export the internal forces of entropy. And there's several ways that organisms are able to do this. But they actually have a very simple immune system, which is made up mainly of non-clonal immunocytes. They have no T or B cells. In addition, they also must be able to continuously identify the forces of meaning that are in their environment, such as attract free energy, for example, food energy. And they also must be able to embrace the internal forces of meaning that are inside of them, such as be able to reproduce and maintain homeostasis. It's important to point out that these organisms do undergo malignant transformation. They do get cancer, and some of them actually do get melanoma as well. The best examples that we're aware of in nature are clams and mollusks. And we can talk more about that later in a different conversation because it's a really interesting topic. And then the last box, box D, I'm sorry for this super busy slide, but we're almost done. Box D on the bottom right-hand corner finally describes us, human beings, all successful vertebrate multicellular organisms, all with nervous systems, must still be able to identify the external forces of entropy in their environment, stay away from that, and be able to export the internal forces of entropy away from themselves. And we do that, well, there's many ways that we do that, but one of them is having a very, very, very complex immune system. And Steve will be describing more about that later in the presentation. We also must be able to continuously identify and embrace the forces of meaning in our external environment, such as attract food energy. And humans need social support as well from other humans. But we also must be able to embrace the internal forces of meaning inside of us, such as be able to reproduce and do learning and maintain homeostasis. And obviously, these multicellular organisms, all with nervous systems, do undergo malignant transformation and they do get cancer. Can we go to the next slide, please? So this slide describes the summary of what I just described. Specifically, all successful life forms at every single level of life must be able to do two things effectively. The first one is that they must be able to detect the forces of entropy and the forces of meaning in their environment effectively at all times. And they also must be able to continuously move towards the forces of meaning and away from the forces of entropy. So this figure that you're seeing here basically shows chaos in the middle. And chaos, it's really important to understand this, chaos is not the same as entropy. Chaos is kind of like a mixture of the forces of entropy and the forces of meaning. And chaos is actually the way that all living organisms actually experience life. So all living organisms, number one, must be able to do accurate true states detection of where the forces of entropy and where the forces of meaning lie in every moment of chaos. And they also must be able to do accurate error correcting motion to keep making the chaos go towards the forces of meaning, and the ability for any organism, including single cells, to be able to do accurate true states detection and make an effective error-correcting motion towards the forces of meaning is labeled as intelligent motion. Next slide, please. So this is basically the summary slide of these last two slides, and I'm almost done with my part here. So this slide specifically describes the 4 essential functions that every successful cell must be able to do. And we're going to start at the bottom left-hand corner. I hope that you guys are able to see this and it's not blocked out by the icons on the screen. At the same time, I can also hold it up for you here. So first box on the bottom left-hand corner right here, every cell, and this is an image of a cell, in orange is the cell membrane, in light blue is the cytoplasm of the cell, and dark blue represents the nucleus. So going back to the bottom left-hand corner of the slide, every single cell must be able to effectively attract the forces of meaning in their environment, such as free energy in the form of food energy. And every time they attract forces of meaning in their environment, their environment specifically is always changing. The forces of meaning in their environment are always changing. Moving on to box 2, on the top left-hand corner, every single cell organism must also be able to recognize and avoid external forces of entropy, the same entropy that we've been talking about for the last 10 minutes. And the forces of entropy in every cell's environment are constantly changing, so the cell must be able to effectively detect where the forces of entropy are and stay away from that in their environment. The third function that every cell must be able to do on the top right-hand corner now is that they must be able to efficiently export the internal forces of entropy away from themselves. And every time single-cell organisms are doing this, or any type of single cell, they actually produce changes in their specific environment. Their environment changes as a result of the entropy exportation of the cell. And now we're here at the last part of the slide, box 4, on the bottom right-hand corner. Every single cell must be able to accumulate resources for replication, for reproduction, for homeostasis, and for learning. And this green triangle here specifically states or diagrams that there's always a constant relationship between the internal forces of entropy and meaning and the external forces of entropy and meaning. And the organism must make special motions to be able to maintain effectively that relationship. And when this function in the organism begins to fail, then the organism must actually learn new adaptive homeostatic motions. So learning is a huge deal in this model. Next slide, please. So this is my last slide here, and then I'm going to pass it back to Steve. And this is going all the way back to the first title slide that you guys saw. And it's going back to the question of why do scientific models of disease actually matter? The reason is because every time you have a specific model of any disease, then that model is going to dictate the specific treatment approach that you take for that disease. There's many examples of what I just said. The two most common ones and the two easiest to understand ones are, first one is the model of ulcers. So for the longest time, doctors thought that ulcers was caused by, well, they didn't really know the cause. And because they didn't know the cause, then they could not specifically point out the treatment that the patient needed to get better. It was so crazy that some patients, for their ulcers, actually were getting psychotherapy. And that's obviously not right. What happened is that one person figured out that there's just one type of bacteria causing ulcers in patients. And that bacteria, H. pylori, actually causes the ulcers. And all you have to do is give the patient antibiotics and they'll be good to go. The second example of the same idea of how scientific models of disease actually produce specific treatment approaches is cervical cancer. We did not know what cervical cancer was being caused by. And when we finally figured out that human papillomavirus, HPV, was actually a huge part of it, then we realized that we must develop a vaccine for HPV, and we have developed that. It's called Gardasil. So now we just make it our business to give teenagers a Gardasil shot as a preventative measure for cervical cancer. So the last part in this slide, very, very important to 2020 pandemic America, is the question of what human price is paid when the scientific models of our disease are wrong. For example, the misguided scientific ideas and the interventions in the U.S. scientific response to the 2020 COVID pandemic is completely different than the response of countries such as Taiwan, Hong Kong, and South Korea. So I hope that out of curiosity, you guys will enjoy Googling Taiwan COVID stats, Hong Kong COVID stats, or South Korea COVID stats. And the reason I'm asking you to do this is because it's shocking how well the Taiwanese scientists, how well the Hong Kong scientists, how well the South Korean scientists have handled the COVID pandemic compared to our scientists. For example, I was very, very surprised to find out that the entire country of Taiwan, which has about 25 million people, only has 7 deaths from COVID. Only 7. That's it. Only 7 people lost from the 2020 COVID pandemic. And United States, on the other hand, as of November 5th, 10 o'clock in the morning, or 11 o'clock in the morning, we have lost more than 235,000 Americans to the COVID pandemic since it first came online. So there's something very, very different in our models. And because our models of looking at the disease are different, then our approach to the disease is also different. So with that, I'm going to turn it back to Dr. Steve. I hope that this part of the presentation is helpful to you in understanding what's coming up next.
Okay, thanks, Ananya. So now, if we could have the next slide. We're going to be talking about 2 different approaches to thinking about melanoma, and the one that we all utilize the most is, and it's in every conversation that you'll have about melanoma for the next few years at least, is called the bad luck hypothesis. You've heard it many times. This slide summarizes it. It basically says that each of us inherits a certain sort of a genetic weakness, a DNA weakness of some sort, but it's not enough to trigger cancer. But in addition, we are exposed to extrinsic factors like ultraviolet light, smoking, those kinds of things, which produce completely random mutations, which can combine with internal genetic things and suddenly release this monster, cancer. And that transformation of this new biological entity is obviously bad luck for us, but good luck for the cancer cell as it goes on becoming its own new source of meaning, is what we would say. Next slide. We're going to quickly go through the standard approaches. One is surgery. Next slide. So there's nothing about this slide that's new. The ABCDE recognition, big deal. Looking at symmetry, looking at the evenness of borders or unevenness of borders, looking at color variations, looking at the diameter and whether it's evolving or not. This is what you guys do so well in complicated patients. Next slide. When you finally decide to biopsy, the staging of melanoma, as you guys get ready to present cases for board review, it's a little complicated, but I think this slide does a really, really good job of getting to the heart of it. You know, you've got to look at the T part, the tumor part, and in melanoma, that's primarily, salute, that's primarily evaluated through the depth. And as you know, everything greater than 1 millimeter is really problematic. When it gets greater than 3, it gets very problematic. we also are progressively learning how to look for factors that offer prognosis, a poor prognosis, like erosion of the surface, or invasion of structures of any sort. Progressively, we're looking at the number of mitoses and even, hopefully, the immune system cells that are there or not there, and what are they doing there. The next stage, as you can see in the bottom left, is the lymph node involvement. As soon as you get lymph node involvement, you're in stage 3 already, and there's different variations on how bad that can be. And then finally, stage 4 in the bottom right is when the melanoma spreads to other organs, and it can go to virtually any organ, but certainly lungs and liver and brain are huge. Next slide. When you Google different survival curves for melanoma, they're all over the map for a lot of reasons. This is the standard one as of, say, about 2 years ago. I think it's changing very, very quickly, but I don't think we know how to express that yet. But you can see there's a huge difference, say, in 5-year survival between stage 1 and stage 4. Again, that's changing. Next slide. So this is just another way to see or visualize the science of the bad luck hypothesis. I hope you will be inviting advocates of this hypothesis to talk with you, to hear their side of the story. They certainly correlate cancer with the number of stem cell divisions in a tissue, and they think that that's a prime driver of whether or not malignant transformation will occur. But the image that people with this view of cancer have is that they think of sort of a swarm bot kind of a biological threat, calculating, moving, but if you ask them the question, is it intelligence, cancer intelligence, they would deny that. They say this is just caused by purely entropic factors. The other thing that they would deny is that in this model is that the immune system has any direct effect, and that's what we're here to explore. Next slide. This is a slide that just simply summarizes some of the key genetic events that can be seen as the tumor cell process progresses. Thank you, Ananya. This section here is actually the skin on the side. It should be like this, and now you can start to see the different levels of invasion from just, it should be like this. You can see from just simple evidence of melanoma that's inappropriate to deeper pockets of spread, and then eventually to a level of spread that will go to almost surely metastases. And the various genetic progressive markers that have been noted are shown when you get to see this. There's no one-to-one correlation. The one that we talk about the most is BRAF mutation in the 600E position. But that being said, not every patient who has melanoma has a BRAF mutation, and there are a lot of patients that have BRAF mutations who will never get melanoma. So there's no one-to-one correlate on that. Alrighty, so next slide. So the surgical management is pretty straightforward. As we've talked about with regard to the ABCDE, the person's risk of melanoma doubles if they have more than 5 sunburns. About 25% of melanomas arrive from moles, prior moles. You clearly can reduce the incidence of melanoma if you stay away from tanning beds and use SPF 50. Going down to the second bullet, we still have way too many cases, about 180,000 cases of melanoma in 2018. It's up 50% in just 10 years. 90,000 cases were in situ, and another 90,000 were invasive, and approximately 10% of patients will die of melanoma. The definitive approach for staging and for treatment is still surgery. If you can get melanoma in a bottle, that's great. We tend to take primary melanomas that are greater than 2 millimeter thickness with a 2 centimeter wide local margin excision, and then sentinel lymph node biopsy for any primary tumor that's greater than 1 millimeter. That being said, standard lymph node dissection as an adjuvant treatment is getting to be less and less, and we really worry about it with each case. We fret over it. And then counterintuitively, we're doing more and more surgeries to remove metastatic disease. Next slide. Okay, the standard chemotherapy model of melanoma is important because we're including these modern TKIs in that treatment. And the one that you see right in front of you in the blue in the circle is the second messenger of the BRAF-MEK-ERK system. It's a growth factor system. And if there's a mutation in the BRAF, it tends to function as what's called a driver gene. Cells with that will tend to divide in a more uncontrolled fashion. Next slide. Remember that BRAF mutations are purely random as far as we can tell. There's no other force driving it. The great news is we have BRAF inhibitors, as you can see in the upper left-hand corner. The first generation vemurafenib, second is dabrafenib, third is encorafenib, and we have many more that are under development. Remember, it was a BRAF, MEK, and ERK. We're now developing downstream inhibitors as well, like trametinib, cobimetinib, binimetinib, and let's go to and as you can see, treatment-wise, this Kaplan-Meier curve shows how with treatment you can start to improve the disease-free survival of patients. Their survival is improved if they're receiving this combination. I think we're getting better and better with the use of these every day, but as you'll see, next slide, please. They still obey the more is better mindset. Remember, that's what Ananya was saying with the chemo. The more you can give, the better. And the side effects of these are real. There obviously many other organs are susceptible to these agents, and I would say more than 50% of people get sick. Around 10% or so just can't tolerate it at all. And the other problem with chemo that they share is that over time, the vast majority of tumors, even if they respond, will become resistant. And that's a problem we want to solve. Next slide. Radiation therapy is, next slide please, is definitely part of our team. It's, in general, melanoma tumors have been thought to be radiation resistant. That being said, they are still used a lot in our patients as adjuvant treatment and palliative treatment, and hopefully we'll get a chance to talk about the role of radiation to launch the abscopal effect in immunotherapy. Next slide. And this is a typical algorithm like you see on the NCCN guidelines. We always go with each one of our patients to the NCCN guidelines to see what recommendations they would have. At the same time, as you'll soon see, in most of our cases, or a lot of our cases, our patients are way off the algorithm. They're in a space that the algorithm hasn't penetrated yet. But here's the basic idea for radiation for multiple metastases of the brain, get whole brain, or stereotactic. We've had very good luck with both. Next slide. So now we're into the immunotherapy revolution. I'm going to try to go through this fairly straightforwardly. Ananya, thank you for the great background you put, because now we can really talk about what is it we're trying to do with immunotherapy. Why does it work at all? So as this figure shows, and it's just an extension of what Ananya has already shared with you, a patient, any one of us, is constantly using our nervous system to look for threats of entropy in our environment, but also the sources of meaning, the things that make for higher levels of sustainability that are in each moment of time. They're always in each moment of time. Unfortunately, they present to us is chaos, which is not the same as entropy. But if you don't make that error correcting motion towards the forces of meaning, then you should expect progressive levels of entropy to emerge. And that's what she just described. So it turns out that that's happening exactly inside of our bodies as well, that there's this system, the immune system, that we're going to go into now, and that it's actually monitoring a space of around 100 trillion cells. That's minus all the bugs that are in there. And they're all talking to each other. All these cells are talking to each other. 100 trillion cells talking to each other. It's a universe of things in there. And there's a lot of rough stuff that happens, from viruses, bacteria, fungi, and cancer. The immune system is able to detect the entropy threats inside of the body and make the error correcting motion to eliminate them. It can't be overemphasized, the mystery and that the brain, what it's doing externally and what the immune system is doing internally, is protecting exactly the same time space, the same Steve time space. Both are working together. We really do need to move past this idea of mind-body effect and other sort of vague things to see these are entropy detecting systems that are working in cahoots with each other to protect our safety. Next slide. So this is a cartoon of the immune system. It's a cartoon because to talk about it sensibly, the immune system, would be laughable. It would be just like trying to describe how the brain works. It appears that our immune systems are as complex as our brains, and you can see that it's basically divided, the slide, into two halves. The half to the left is called has been traditionally called the innate immune system. And it's similar to the invertebrate immune system that you described, Ananya. And the part to the right is has been called the adaptive immune system, and this is where T and B lymphocytes and all this clonality happens. That being said, this model is falling apart pretty quickly for a lot of different reasons, but one of them is that maybe both sides are learning, and certainly we tend to hear, when you hear like an anti-PD-1 agent, about things that's happening with the T cells, but increasingly we're learning that maybe much more of the effect of many of these agents is on the innate immunity side. And also the innate immunity side, as you guys explore it, Langerhans cells and other things in your specimens, this may be really important to look at for the immunoprevention of melanoma as well. So this slide is simply saying that this is a cartoon, because getting to the meat of how complicated it is would just be beyond this lecture. But we could definitely do it in another time, do the best we can. Next slide. So here's the second claim, that from an immunotherapy perspective, we can say that it looks more likely now that melanoma and other kinds of cancers are not random, but that the evolution to a state of becoming a malignant cell might be extremely common, and that they are fully equipped to outcompete other cells for resources, and that's what they're trying to do. In some of the invertebrates, like mollusks, we know that they're actually trying to become external free living things, their own species. They just go out into the cold, cruel world just like the rest of us and infect other animals. They're kind of a parasite. Tasmanian devils have the same thing. If you Google Tasmanian devil facial cancer, you'll see that they develop these transmissible cancers that are now being labeled as independent species. So, we have already said, just as the CNS protects the host from external threats, the immune system is protecting the host for internal entropic threats. And now this new idea comes up. It's called spy versus spy. It's shown from that Mad Magazine cartoon. And the idea that it's constantly looking for cells that are no longer supporting the host anymore. It's an entropic threat like a virus or a bacteria, and that it starts to engage cancer cells at the earliest phases. And then from this perspective, from the spy versus spy, we wind up with extraordinary new conclusions like melanoma and other cancers may not be rare. And in fact, they may be not even random. They may be a type of a cell, a previously normal cell, melanocyte, that detects a weakness in the surrounding environment and then suddenly decides to access a subroutine like a embryonic stem cell routine and then become its own source of meaning. That seems to be the model of it, and that the emergence of cancer is more a failure of the immune system than it is the aggressiveness of the cancer cell itself and the intelligence of the cancer cell itself. Today, I can say when we meet new patients with advanced disease, brain mets, etc., we can say confidently in melanoma now to say to that patient that we know that the resources to identify those cancer cells and to eliminate them are in the patient at that moment. We just have to find a way to wake that up. This is an extraordinary idea, and it leads to the possibility of us now having vaccines. Next slide. This is an emerging list of the different kinds of immunotherapies we use on a routine basis, from stimulator molecules of different sorts to checkpoint inhibitors. It turns out the immune system has brakes on itself, and you can take those brakes off. Oncolytic viruses like TVEC, TIL therapy, and of course CAR T therapy and other adoptive immunotherapies, cytokines like interleukin-2, nonspecific stimulators like imiquimod. We already mentioned local radiation therapy, cryotherapy. There are still there have been many melanoma vaccine trials that have taken place. All have been negative to date, but new ones are being considered. And even the gut microbiome can dramatically affect the patient's response to immunotherapy. The most perhaps important aspect that we're going to talk about here is that in immunotherapy, more is not better. It's more like treating a diabetic. More insulin isn't better. Just figure out what they need to get the right metabolism going. And that's how the game is played. And now we say then only better is better for that patient. Next slide. So this is the brief outline of how we're using immune checkpoint inhibitors. If you look on the left-hand side of the graphic, what you'll see is that in addition to processed antigen being presented by the macrophages or antigen-presenting cells in conjunction with MHC and triggering the T-cell receptor, there are these co-stimulatory molecules as well, CD28 and CTLA4. Actually, both CD28 and CTLA4 compete for binding with B7, and if CTLA4 is able to grow enough on the T cell, which happens over time, then it's actually going to shut the whole thing down. We can inhibit that by simply binding covering up the CTLA4 molecule, and then the T cell response goes into high drive. The anti-PD-1 therapies are designed, they're antibodies, they're monoclonal antibodies, ipilimumab for anti-CTLA4 and Nivo and others for anti-PD-1 are just antibodies, and the business end is designed to grab an IPI to CTLA4. For Nivo, it's to PD-1. PD-1 is a senescence molecule that's progressively expressed on immune system cells and targets them for destruction by covering them up with Nivo or any other anti-PD-1 we can give new life to that cell. Next slide. These are the kinds of charts that we could do in some other in-depth review. We've already looked at a Kaplan-Meier type survival curve on the left, but then there's on the top the so-called waterfall plots where we track each patient, how many of them have progressive disease versus how many the tumor burden shrinks. And another way of expressing the same thing that does provide more information for individual patients is shown on the bottom right, the so-called spider plot, and shows how different groups of patients are responding to each of these immunotherapy interventions. Next slide. It turns out that when we're able to talk to the failing immune system of a cancer patient such that they're losing the spy versus spy game, and then get them wake up with these anti-PD-1, anti-CTLA therapies and others to say recognize the tumor threat of entropy and do something about it, that you can get some pretty crazy stuff. And one of them is something called pseudoprogression. And this is a patient who had melanoma in a lot of places, but it started in his ear and then just went all the way down his neck into his lungs. And what we could notice is when he was responding to the immunotherapy, his tumor got dramatically worse. And this is called pseudoprogression. What was actually happening, we have lots of biopsies, etc., was immune system cells were moving into that spot. It was ugly, but then suddenly everything responded. The ear you see at the bottom left, section D, is totally healed. That blue stuff is the melanosis that's left over by macrophages. But he went into complete remission. Next slide. So we use immune checkpoint inhibitor therapy as adjuvant therapy. And a typical way to do it would be to give Nivo at a schedule of 240 milligrams a hit every 2 weeks. But we can also do it on a monthly schedule at 480 milligrams. We're doing this for a number of different patients who have been rendered NED, but have high risk. That's what we want to know with all the staging. What is the risk of recurrence? And the more that we are worried of recurrence, we will attempt to use this type of adjuvant immunotherapy first. Next slide. So we are able to get dramatic We're able to get dramatic improvements in patients with metastatic disease. Every month we're getting better, but it's I would say the majority of patients now, between the use of TKI, immune checkpoint inhibitors, and others, the majority now we're able to get into disease-free status, like the case of Mr. Banks. Many times it's a process, but it still works. The problem is that the toxicities of immune checkpoint inhibitors are always autoimmune. The problem is when we take the brakes off of the immune system with anti-CTLA-4 or anti-PD-1, that then we can't do specifically. We can't do it just for that clone of T cells that responds to the melanoma, but instead to everything. And you can get autoimmune disease of any kind. One of the things we'd like to talk about today is the dermatologic manifestations. So we partner so closely with dermatology, not only in the diagnosis, the staging, the planning a multidisciplinary approach, but then when they get immune checkpoint inhibitors, how to monitor skin toxicities. Some of the ones that we see frequently are erythema multiforme, Stevens-Johnson type syndrome, toxic epidermal necrolysis, and alopecia. But one we're going to talk about that we love to see is vitiligo. Can we have the next slide? And this is it. So I hope this comes across to you. This is the hand of a patient who's undergone a complete response to therapy. And the first lead that we got that it was going to happen was the development of these vitiligo spots. Very, very unusual pattern. What's crazy about this when you see it is that it's almost always completely symmetrical. So his other hand looked exactly the same. Same pattern. And by the way, he never had melanoma in this part. This man had brain mets and lung mets. But this developed. It's always a good sign when we see it. And I'm confident that if any of you can figure out why is it symmetrical, what causes that, you will definitely get a Nobel Prize. I'll certainly do my part. Next slide. The toxicity management in general, we're going to go into dermatology in just a second, but the multidisciplinary team approach to management of toxicity is as the grades get higher, we first try to do symptomatic therapy if that'll work, and we just march through therapy. The next thing we do is stop therapy. The problem is that there's no washout period for these agents. This is a crazy idea. This is hard to grasp. But once a patient gets anti-PD-1 therapy or IPI, they can be at risk for side effects of all sorts for up to 2 years afterwards, even if they never see another dose. And that's telling us something about how these treatments, these immunotherapy treatments, are interfacing with the adaptive learning function of the immune system itself. When things get rough enough, we start to stop therapy and give prednisone or some other corticosteroid. And if things get bad enough, we can always rescue the patient. We can always get them back to normal, but sometimes they never go back on immunotherapy. Next slide. We are now at an exceptional program. When I was being trained, we used to have grand rounds and have patients with us all the time and talk directly. We're doing it so little now. So the treat, and I want to thank everybody from the leadership level, but especially Sang Kim and Alexander Rosenberg and Michelle Bongiorno sponsor a space where you could talk. I'm hoping, I haven't heard any interruptions. I hope you're going to want to talk to the patients. Patient power is huge. We talk about scientific modeling with our patients directly so that they can know what are the ideas in play and how the 8 different disciplines are seeing cancer differently. We also talk about the different treatment approaches. For example, should they consider chemotherapy if they're BRAF positive, like TKI, or immune checkpoint inhibitors?
Are there any clinical indicators like vitiligo or others you've noticed over the years that may indicate why a particular patient may require just a few infusions of the checkpoint inhibitor versus, say, dozens of infusions with really no endpoint in sight?
So this is a profound question. I'm going to repeat it again, if nothing else, for the YouTube. So how are you, Steve, what you're saying is you see a new patient and you're working off this spy versus spy idea, and you're thinking that their immune system has kind of gone into a coma or something, and you need to find a way to talk to the immune system and get it to wake up, identify the entropy, and eliminate it. Do you have any clues about where their immune system is at and why it went down? And can you use those to guide treatment? Not just the type of treatment, but the length of treatment. So we really should consider getting together and talking more about this at a later time. But in brief, the answer is we have no clue. Zero. And in fact, we're still held hostage to the bad luck hypothesis of cancer because until just a few years ago, maybe 18 months ago, the FDA and all the other approvatrons kept saying that the best immunotherapy is the most immunotherapy. So, for example, Mr. Banks received ipilimumab at this extraordinary toxic dose of 10 milligrams per kilogram. We lost so many people to toxicity from that. It was crazy. And again, more is not better in this idea. So just to prove this point, if you ask then on adjuvant therapy, why would you give it for 240 milligrams for 2 weeks, but then you could double it for a month and give 480. What's the rationale for this? Answer, we just made it up. It seems to work, but we have no idea why. More than that, why is there 240 milligrams for everybody? I have one patient that only weighs 48 kilograms, and Mr. Banks weighs a few more than that. Why do they all get the same dose? So we have a lot of issues there. We definitely need to find, and it may be on the past specimens you guys look at, little tricks to say, what's going on here? How long has this gone on? And what can we do? I hope that this response is helpful. This is really the in-depth science of a cutaneous oncology tumor board meeting. And again, the youngest among us that lead our conversations do a brilliant job of sorting through those issues. But we definitely need to get better. So is there any other questions before we go on? So we have talked about the multidisciplinary part of it and to prepare the patients to see these other parts of the team and to talk together. The risks keep changing, and as patients go into new treatments, and that has to be explained in informed consent. And of course, cost is becoming a huge thing. You know, there's about 1 in 2 Americans now get cancer. We're still losing, unfortunately, 600,000 Americans to cancer. About 9,000 are melanoma. More than 40% of patients with advanced cancer become totally wiped out financially, including to the point of homelessness. So this is these are all things that are going on in that space. And so on one hand, we help as quickly as possible to help patients understand they're in a unique scientific experiment if this spy versus spy thing is true, and we need to learn from everything that we can. And we also need to help avoid medical misinformation. And so we do everything we can to grow a creative language of exchange so that they can be effective partners in their own care. And no better example is right here than Mr. Banks and his wife. Mr. Banks, would it be okay if we gave you, say, 10 minutes to start with to talk about anything you want to talk about? Just briefly, I just want to say the obvious. They're alive and awake and very, very critical thinkers. Our practice of immunotherapy has improved dramatically because of the feedback we've received from Mr. Banks and his wife. They are very active members of their community, and they have not let this disease slow them down. They're also vibrant members of their church, and they have graced our clinic tremendously by bringing faith. We've had some pretty rough conversations from time to time, and we've definitely asked for healing to get through them, and we have. And one last thing that should be obvious, we just don't see that many African Americans in the melanoma conversation, frankly, either as physicians or supporting staff or patients. And hearing from Mr. Banks and his wife in that perspective is, I think, a real blessing as well. So with that, I'll turn it over to you.
Hi, I'm Mr. Banks, and I want to tell you a little about the procedures that I've been going through with having been diagnosed with melanoma. It's been first I was devastated when I found out I had melanoma, but I never could understand, I didn't understand the disease, but when I found out how deadly it was, and then my whole mind and focus a lot about the disease. I started off with just a little spot on my foot, and it metastasized later on in my foot. And I think I had Dr. Shriver, who did the surgery on my foot, and that was it was 16 years I was cancer-free. And I thought I was okay. But one thing he did, have me to do is have a PET scan every 3 months. But it went on for about 10 or 12 years, and they felt as though I was cancer-free. But after that, when I found out it had metastasized, and I didn't know how bad it was. So I was told in 2013, I was told I had to have amputation of my leg, and that was a hard decision, but it was dealing with my life. And I ended up having an amputation, and I was treated with chemo, and I was treated with the X-ray. Radiation, and that put a toll on me as far as my body was concerned. But during this whole time I was going through this sickness, I never gave up hope, because I had the idea. I was at Walter Reed, and Walter Reed, what it was, I had doctors who gave me hope and letting me know that at times how with the PET scan and the blood work that I was getting better. But after that, I found out that it came back again in my lymph nodes, and that was a couple years later. Then I had to have surgery after surgery. I stayed in Walter Reed Hospital for 5 months, and during that 5 months, it was a touch and go situation. But I learned through this sickness is that, and through the doctors who really inspired me, because they never gave up on me. And what happened to me, when you're dealing with a illness that affects your life, it changes your whole way of thinking. And what I did, I just focused on me being spiritual. I prayed about it, but I also understand through being in the hospital and seeing a whole lot of other people go through certain cancer treatments that I understand that at times it might not work. But I never gave up like I said, I never gave up hope, and I continue on listening to what the doctors came up with their diagnosis on me. And I guess through different types of treatment, and especially that I think that radiation treatment I think that really put me in a bind, because I lost my appetite, I lost weight, my resistance was very low. I had no resistance. I stayed tired all the time, But being in a hospital setting, I had physical therapy and other medical treatments to help my condition. But what I've learned through this whole sickness, that I had to listen to each and every time. I had to listen to the medical diagnosis of my illness, and I had to. That's where my faith really increased, because at my age, especially today, when I was really sick, I was 65 years old, and this happened to me 16 years before that. But I understand through listening to your doctors and keeping having faith. Hey, I come a long way with this this treatment. And one thing I can say, up to date, I don't have the tiredness like I used to. I may, after the first day of taking my treatment, I may feel a little tired. It might not be until the next day, but I'm still able to, I'm able to live my life. And I continue on every 2 weeks, have my, my blood work, and my treatment is every 3 weeks. So I'm one of the ones who saying that I'm blessed.
There is another dimension to every one of our patients. From the first moment in dermatology that they know they have melanoma and the white excision and follow-up monitoring, all the way to advanced cases like Mr. Banks, and that's the caregiver. We just celebrate our caregivers in our clinic. They just are anchors of sanity for all of us. Mrs. Banks is no exception. I mean, one of the questions that is hard to grasp for any of us is, how does a caregiver start to process the shock of knowing now there's melanoma in the family? And what is it that they need to understand about the spy versus spy dimension of immunotherapy versus any kind of a chemotherapy or a radiation therapy or direct attacks on the cancer? The idea that immunotherapy may be for the rest of their lives. Mr. Banks I think he's gotten around 60 treatments with Pembro, for example. And how does she process this? What's the best way to support patients from a caregiver's perspective? And how can the caregiver help to support collaborative learning relationships between the patient and their many doctors? It's a lot to juggle. And on top of that, how does the caregiver take care of themselves? Because if you're not there, then what happens next? So with that, I'd like to turn this over to Mrs. Banks.
Hello, I'm Mrs. Banks. It has been a challenge for me. When I first found out that he had melanoma, well, I was the one who discovered the mark on the bottom of his foot, but he ignored me, as men do. And it was just by chance, not chance, it was God. He had dropped something on his big toe when he was in Atlanta in the military, and when he came home, it started pussing. And he went to see a dermatologist at one of our local facilities, and the doctor there he was a dermatologist, asked if he could take a biopsy of that mark on the bottom of his foot that I had kept asking him to go see about. And that's when they discovered he had the melanoma. From there, they had to gut out his foot, and he had surgery and what have you. And we went through that. It was kind of hard, but we got through that. But in 2013, when they said it had spread all the way up to his leg, and he had to have his leg amputated, that was really something to process, because we never thought about him having to have something that drastic done. When he went in the hospital, it was a new life for us, because we stayed he stayed in the hospital for 5 months, and then we both stayed at the Fisher House. We had to stay at the Fisher House. So I had to leave my home, my friends, my family, to be with him at the Fisher House. But, God is so good, because he sent so many people. My friends would come, my church members would come. They would all come to visit us. They were so supportive. And you need things like that. When you're going through something like that, you need the support, because I felt so alone sometimes being there, because I would be at the Fisher House and he'd be in the hospital. And I would feel so alone sometimes. But so many people reached out to us. So many of my family, so many of my friends, so many of my church members, they would come stay with me, spend the night at the Fisher House with me as well. And so I learned that I had to trust God for every situation. When he would go speak to the doctors about the next step to take, what he should do next, I always let him, we always prayed about it, and I let him make that decision on his own because this was his body. But we always talked about it and prayed about it before we made that decision of what was going to happen. Like I said, having a support system is so good because without it, I don't know how I would have made it. My friends would come sometimes, and sometimes my brother-in-law would come stay with him so I could go home, take care of things at home, go to work sometimes. I had a little part-time job. I would even go to work sometimes. It was just good to go be around the people and go to work and, talk to them. I did convention work, and so it was good to do that. And like I said, my brother-in-law would come and stay with him for a week because he had to have somebody with him at the Fisher house. I tell you, the biggest thing was when he got his prosthesis and his prosthetic, and he started walking again. I remember the first time he took steps on his own, I felt like a mother looking at her child walking for the first time. And I had to call my daughter and everybody and FaceTime and look, he's walking. And I'm so glad that we never gave up. He never gave up. He was determined that he was going to walk. I've known people who've had their legs amputated who just gave up, who stopped living, they thought they couldn't do anything. But one thing about my husband, he never gave up, and we never gave up on him. And I mean, if people see him now, they don't even realize that he has a prosthetic leg, until he shows it or something, But it has, like I said, it's been an experience. And I thank God that we went through it. And it has brought us closer together as husband and wife. It has brought me closer to God. It has strengthened me because now I know if I can go through this, I can go through a whole lot of other things. And you have to have people around you. You have to be able to trust. And that's what I had to do. I had to trust. I had to so much. And it's so good to be able to have people around you to support you and, do what you can for him, but also take care of yourself. And I have friends who come, take me out, come here, stay with me and things like that. So that was such a big help.
I can just verify how much courage and mental clarity these two bring to every moment. There's no other way to explain how they could have survived 20 years so well. They are surviving so well. They're an inspiration to be with. They're fun to be with. One of the most extraordinary things about them is when they meet them, they always are concerned about other people, and they talk about their concern about other people. They're not just letting this disease bring them down. And of course, obviously others reciprocate. And so that's huge. When Mrs. Banks was talking about how Mr. Banks survived the prosthesis, and when he walks around, you'd never know that he has a prosthesis. It's just shocking how physically adept he's become. But it's more than that. I got a shocking phone call about, I think it was about 2 years ago, roughly, from the dental clinic saying, we have this guy here that's thinking about getting dental implants to replace his dentures with dental implants. And we notice there's this metastatic melanoma business here. That doesn't sound right. It takes a long time, etc. He said, should we go ahead? I said, definitely. I said, he's disease-free. He's determined to stay disease-free. And I was talking to a sort of a young dentist, etc. Very thoughtful, said, but don't be surprised if he outlives all of us, okay? And that turned out to be prophetic. He's done very, very, very well. So we just don't place any limits to the amount of support we give our patients. They have every reason to believe that they can remain disease-free. Does it take a lot of work? Well, now we're back to the 8 disciplines and the continuous oncology tumor board work. But yeah, it all works well together. Is it okay if we go to the next slide then? Oh yes, Mrs. Banks has one more thing.
Yes, one more thing I wanted to say too about support. when my husband would come to doctors and all, and we would speak to the different doctors, and especially his oncologist, Dr. Perez, the one thing that really helped us get through it was their spirituality as well. When you have doctors who think they're doing it on their own, and this and that other, but when you have one that let you know that they pray as well, that they believe in God and things like that, it sort of helps ease you a little bit. And I just wanted to make that point, that it's so good to know that you have doctors who are spiritual, who believe in God, and know that they're not doing this on their own.
Mrs. Banks, thank you for that, and thanks for all the spirituality you bring to the clinic, not just for your husband, but really for everyone there. You're so generous in that way, and you make it safe for us to say the obvious, and that is that doctors are not gods. How simple is that to say? And so there's other forces at work. I always have the same prayer I say every morning, please, God, help me to make whatever plan for health you have for that patient happen, and don't let me get in the way of the health they deserve. And Mrs. Banks, again, I want to thank you for making that conversation always possible. Okay, with that, we'll go to the next slide, which you have about the two models of melanoma and how they can work together in the treatment of advanced or high-risk cases, and how they can get in trouble with each other. Are there any questions now about this case and where we want to go with this case, or do you guys have any cases that are comparable that you kind of want to talk a little bit about? Saying, if you don't have anything on your end, what I can say is that on this particular case, the case keeps getting represented at Cutaneous Oncology Tumor Board for a reason, and that is because the melanoma is very, very controllable. It does not affect his life, but as you saw as recently as 6 months ago, a little patch came back. The ability to say, well, look, it's not happening. All the other areas of metastatic disease didn't happen, didn't come back. Could we try local and see what happens? We're taking a gamble, but so far it's paid off. The idea that this man has well-behaved melanoma, to me, seems preposterous. It's been extremely invasive. He had massive abdominal disease, and he was extremely sick from that, and now he doesn't. But at the same time, the idea is that he's likely going to need some form of immunotherapy for the rest of his life. But going back to the prior question, how much is that supposed to be? On the outside, they tend to cut off treatment at the end of about a year of disease-free status. We're privileged in our institution to be able to go further, and I think that's the right way to go until he has serious side effects. The great news is, at this point, he has not had any autoimmune side effects, and that's wonderful. Okay, if you don't have any more questions about this case or comparable case studies, let's jump into the board review questions. So next slide. So here's the kinds of rashes that we see extremely commonly in these patients. Maculopapular rash of varying severity, and not just the cosmetics, but the itchiness can be excruciating. They can get keratinocytic neoplasms, particularly if they're taking TKI as well, and we need the help of dermatology to monitor for that. They can get all kinds of psoriasis-like eruptions, and then they can also get lichen planus and lichenoid eruptions. Next slide. Most of these conditions can be monitored and controlled with topical therapies of different sorts for the itchiness, and also steroids to keep things at bay. But sometimes they need more aggressive interventions. The problem is, in addition, they can just suddenly, out of nowhere, present with bullous pemphigoid or Stevens-Johnson's like toxic epidermal necrolysis. When that happens, in my mind, I just walk immediately with the patient over to dermatology to try to see how to confirm this and to try to formulate a treatment plan. It's not uncommon that these patients get hospitalized when that happens. We certainly stop the treatment, but then please, I beg you, realize that when you stop a Nevo treatment, the risk of side effects, of autoimmune side effects, can go on for another 2 years. So there's no washout period in a traditional way. Next slide. So the kind of work that we do well in medical oncology and derm with skin toxicities is to make sure there's a thorough history, to get the cancer diagnosis and all the treatments on the record, to categorize the onset of the rash and the severity, and any comorbidities of any sorts, and any other sources that could have caused a rash. We obviously do a total exam. We have to check the BSA and to see what percentage of the skin is involved. We do photo documentation, and we will typically do a CBC and do basic labs, LFTs and kidney function, only because this may not be an immunotherapy side effect in isolation, and we want to make sure we've got it focused. Next slide. So the grading of reactions is a big deal, and as you know, for the mild, we can usually do symptomatic therapy only. By the time they go to moderate, we're definitely going to withhold treatment, but that may not be enough. Almost certainly we're going to jump in with steroids, and then depending on how they recover, will be depending whether they go back to getting any additional immunotherapy treatment, at least that type of immunotherapy treatment. We consider dermatology in our institutions sooner rather than later. Grade 2 reactions can wait a little bit, but grade 3, like I said, I just walk them over and we start to figure out what to do together. It's a real privilege to have that ability. Next slide. So before we go into this case study here, I just want to say one other thing that doesn't come up in the literature, but I think over time will come up, and that is, what are these side effects, these autoimmune side effects, telling you about the immune system of that patient? There's a kind of a comforting feeling when you start these treatments and get a side effect of any sort, because it's telling you that you're now talking to the immune system. It's not necessarily the one you want to see. If I see the vitiligo thing pop up, then I'm sure I'm on target to where we need to go. And I think we need to spend more time and try to categorize responses, even adverse reactions that we don't want, to say, what is that telling us about the immune system and how likely it is to start to wake up and identify the melanoma threat and deal with it. That's an unprocessed area right now, and we could really use some great research at learning how to use adverse reactions of all sorts to let us know more about that initial question was asked earlier. What is the problem with the immune system, and how do you know that you're getting it to wake up, and then how long does it go? Right now, all we have is vitiligo. So in this case, we've got about 8 minutes or so. Here's a 60-year-old man, metastatic melanoma, treated with anti-PD-1 and anti-CTLA-4, likely like a IPI-NIVO combination. He's tolerating the treatment well. His lesions are decreasing, and now he develops a pink pruritic rash on his trunk and upper extremities. Next slide. So the treatment of this, the management, this would obviously be a low grade. We would definitely continue the checkpoint inhibitors. We would check the CBC and metabolic panel to make sure there wasn't other things like hepatitis or autoimmune nephritis. Any part of the body can develop autoimmune disease. No limits. They'd get topical therapy and then a non-urgent dermatologic referral, just working non-urgently with the dermatology consultant. By the way, the dermatology consultant for each one of these patients is vital for another reason, and that is because we need to keep mapping their skin. We need to make sure there's no emergence of new lesions. So all of our metastatic patients have vibrant relationships with their dermatologists. Next slide. Here's a more advanced case. This is the case with blisters, starting on the hands and then spreading to face and back, a gritty sensation in the eyes. So this patient would be walked immediately over to the intensive care unit. The dermatology staff and medical oncology staff would jointly monitor her care. She will definitely get high-dose steroids, and in this particular case recovered after a 2 or 3 week period. She'll never get that immunotherapy again, anti-PD-1. And whenever a patient has a grade 4 level, we don't re-challenge them with that agent. Next slide. So we're coming to the end, and I'm happy to, well, I'll just close it out and see if there's any final questions. So this cancer immunotherapy revolution is growing. There's no sign it's going into the bottle, fortunately, as the Science magazine article points out. Every time we have a patient that goes into complete remission that lasts a long, long, long time, it's kind of a new definition of cure, then we have to keep revisiting to say, what are we doing right with this approach? It's obviously completely different than the more is better chemotherapy approach, for example. But at the same time, we want you to know that in the case you've seen today of Mr. Banks and Mrs. Banks, they have advanced our thinking dramatically, not just for how to handle their case, how does their spy versus spy story work, but also for other patients in our clinic. And I want to thank you on behalf of the other patients. At the same time, I can't emphasize enough the fact that there's a new door that's open that was never predicted by the bad luck hypothesis of cancer and will never be addressed by the bad luck hypothesis of cancer, which is what are the chances now that we could learn enough about cancer immunosurveillance, melanoma immunosurveillance, so that we could develop a true immunoprevention vaccine for the future generation. I don't know if I'm going to make it to next week. Well, we have a clinic date tomorrow, but I'm hoping to get there tomorrow. But I don't know if I'm going to make it to next week or to next year. But my prayer is that some of the youngest among us will pick up on this and remember that our dream was that we wanted that vaccine for everyone. Can I have the next slide, please? It's worth acknowledging all of the people who just helped on this presentation alone and that do such brilliant work at our COTB conferences every week. It's every Wednesday at noon. It's really, to me, the most enlivening, informative cancer conversation in town. And I want to thank them so, so much. Mr. and Mrs. Banks, we used to do this in medicine all the time, have grand rounds, have the patient, etc. We don't get to do it now at all. And with COVID, talking through a screen, how hard is that? But we're doing it. Thanks all of you for sponsoring this. I hope you'll remember them when you see, as dermatologists, you're their guides. You never stop being their guides. Now that you know what could happen down the road, but you'll always be a part of it, even with if they're in cancer checkpoint inhibitor therapy. Hopefully you can be more confident about something that's very, very dynamic.
We hope that you enjoyed watching the presentation, that it was useful and most importantly empowering. We hope that you will enjoy sharing it with someone who you know has been diagnosed with cancer, a friend, a loved one, a family member, and we hope that they will find this useful and empowering as well. Please leave a comment with feedback or questions or suggestions for what we should make our next videos about. And if you like this video, please leave a thumbs up and subscribe to our channel for more similar content.